Hello everyone, my name is Do Hyun Park from the University of Ulsan College of Medicine Asa Medical Center. I am a professor of gastroenterology.
I'm Gunn Huh, a clinical assistant professor of Department of Gastroenterology, Asan Medical Center.
I'm Ho Seung Lee, clinical assistant professor in Korean University Annam Hospital. Today, we are here to discuss our study entitled Real-World Outcomes of Endoscopic Ultrasound-Guided Tissue Acquisition for Actionable Diagnosis in Suspected Primary or Recurrent Lymphoma.
Dr. Huh, could you briefly explain the background and clinical rationale for this study?
Certainly, although excisional biopsy remains the gold standard for diagnosing lymphoma, it is often difficult to perform in patients with deep-seated lymphadenopathy, particularly in the retroperitoneal or para-aortic regions. This challenge is even greater in patients with suspected recurrence who may already have undergone prior surgery or chemotherapy and are often frail. With advances in EUS-guided fine needle biopsy technology, it has become possible to obtain larger and better preserved tissue samples suitable for immunohistochemistry and subtype classification. However, data on the real-world clinical impact of EUS-guided biopsy in both primary and recurrent lymphoma remain limited. This gap in evidence motivated our study.
Okay, Dr. Lee, could you describe the study design and what clinical questions you aimed to address?
Yeah, this was a retrospective longitudinal study including 87 consecutive patients who underwent US-guided tissue acquisition for suspected lymphoma between 2016 and 2024. We included both patients with suspected primary lymphoma and those with suspected recurrence at prior histologic confirmation. The key concept of this study was actionable diagnosis, which we defined as either definite lymphoma diagnosis with subtype classification or reliable exclusion of lymphoma, supported by alternative pathology or at least 12 months of disease-free follow-up. Our primary aim was to evaluate the technical success, safety, and clinical impact of EUS-guided biopsy in real-world practice rather than focusing solely on diagnostic yield.
Professor Park, could you briefly explain how US-guided biopsy was performed in this cohort?
Yes, all procedures were performed using a linear echo endoscope under conscious sedation. Regions were carefully evaluated with Doppler imaging to avoid vascular structures. Needle selection, including 19, 20, and 22 gauge FMB needles, was at the discretion of the endosonographer, based on lesion characteristics and availability. Importantly, macroscopic on-site evaluation was routinely performed to assess tissue adequacy, allowing additional passes when necessary. Dr. Huh, could you summarize the main result?
Of course, the technical success rate was extremely high at 98.9%, and the overall diagnostic yield was 87.4%. Importantly, actionable diagnoses were achieved in 85.1% of all patients. In patients with suspected recurrence, US-guided biopsy confirmed the lymphoma subtype in 61% and reliably excluded lymphoma in 26.8%, resulting in a negative predictive value of 90.9%. Adverse events were rare and mild, consisting only of transient fever in a small number of patients with no severe complications observed.
Dr. Lee, how do you interpret these findings from a clinical perspective?
Yeah. Our results suggest that US-guided biopsy provides meaningful clinical value, particularly in patients with suspected recurrence. In these patients, the clinical priority is often to confirm or exclude relapse rather than to obtain a large surgical specimen. US-guided biopsy allowed clinicians to initiate appropriate therapy promptly in confirmed cases while avoiding unnecessary treatment in patients with recurrent lymphoma. Professor Park, Your study also evaluated temporal trend in the use of US-guided biopsy over the past decade. Could you explain what changes you observed and how you interpret their clinical significance?
Yes, over time, we observed a clear shift in clinical practice. Early in the study period, US-guided biopsy was mainly used for primary diagnosis. However, its use progressively shifted towards suspected recurrence, powering the adoption of a newer fine needle biopsy device, particularly the 22-gauge acquire needle. This trend likely reflects increasing confidence among hematologists and gastroenterologists that US-guided biopsy provides reliable diagnostic information in the recurrent setting, where the key clinical question is often the presence or absence of relapse rather than architectural perfection. From a broader perspective, these findings support an ES-first approach in carefully selected patients with deep-seated lymphadenopathy. Importantly, even when initial results were non-diagnostic, patient management was not delayed, and definite diagnoses were achieved with additional evaluation.
Professor Park, do you have any final comments for our audience?
Yes, sure. US guided biopsy is not intended to replace excisional biopsy in all cases. However, when performed by experienced endosonographers within a multidisciplinary framework, it represents a powerful, minimally invasive alternative, especially for patients with suspected lymphoma, recurrence, or surgically inaccessible lesions. We believe our findings support its expanding role in real-world clinical practice, and we hope this study contribute to more individualized and less invasive diagnostic pathway for patients with lymphoma. Thank you for listening.